Welcome to all those around the world. We have a fantastic speaker today with Dr. Karthik Madhavan, and he is going to be introduced in greater detail later. We're going to talk about lumbar interbody fusion and how to do it best. He's at the Cooper University Hospital, and again, we're really excited to have him here. He's a bright young star in spine surgery and neurosurgery, and has won several awards for his work. So cool topic, and as always, we discuss some cases first. Before we go on, two very important organizational announcements. You may wonder who the nice-looking man next to me is. That's Dr. Emre Ilmaz. He's a professor at the University of Bochum in Germany and a senior surgeon there. And he's the recipient of the AO Spine International Traveling Fellowship, and we're really honored that he selected our program here at the Swedish Neuroscience Institute for a month. Emre, do you want to say some words of welcome to the guests around the world?
Yeah, thanks for inviting me. Thanks for having me. I'm really honored to be here, and I know about the really broad spectrum that you have in terms of spine surgery. That's why I'm really excited to see how you guys are doing spine surgery, even though I know it from my time here when I was a research fellow, but it's a totally different game seeing you guys in UR. So I'm pretty excited. Thank you.
And then I'll ask him to come here to the middle, Dr. Rado Skujan, our chief of our spine service. Welcome back after a long injury timeout. Everybody wants to know that you're here. Emily, stay right there.
I'm doing great. Thank you so much.
Okay?
It's great to be back. Yeah, no, I'm excited. We've got a great team here at SSF, and obviously I miss being here live in person. Being remote is just not the same. Oh, thank you, Jens. And it's my birthday tomorrow, but we're celebrating early. So thank you.
It's so good to have you back.
Awesome.
Happy birthday, Rod.
Thanks. Good to be back.
Pose for the camera, pose for the camera.
Thank you so much.
So good to have you back. Happy birthday. Rod, here's your birthday balloon.
Awesome. Thank you.
Don't forget it. So without much further ado, I will ask the eminent Dr. Cliff Pierre to take the lead. And we have 4 case presentations. Karthik, are you live?
Yeah.
Do we have our visiting professor live? Yes. Great. So we have 4 cases and relatively quick fire. We'll ask you some pertinent questions, but as always, we'd love to have your advice and thoughts. Cliff.
Thank you. Thanks for that introduction, Dr. Chapman. Again, welcome back, Dr. Skujan, and thanks for being our honored speaker today, Dr. Madhavan. My name is Cliff Pierre, one of the neurosurgery research fellows here at Swedish. I'd like to present a case of a 54-year-old gentleman. He's a retired teacher, had presented to our clinic after having progressive low back pain for the last 3 months. The pain radiated into his bilateral lower extremities all the way down to his knees. He had intact bladder and bowel function. He had tried some conservative pain management, but this failed to provide any significant relief. Past medical history is significant for diabetes, hypertension, hyperlipidemia, had a remote history of alcohol use and fatty liver consistent with alcoholic cirrhosis. X-rays were done, which I'll show shortly. He was intact on his exam and had a BMI of 40. Again, these were the past treatments that was tried before seeing us in clinic. And here he had a standard flexion extension and neutral films. We do see some mild grade 1 anterior listhesis at L4-5. Not well visualized, but you might see some mild lucency at the L1 vertebral body, which prompted further imaging and then brought him to our clinic. Here we have an MRI, axial and sagittal views with and without contrast that shows a large enhancing lytic lesion in the L1 vertebral body that extends to the posterior elements, significantly on the left side. It goes all the way out into the left paraspinal muscles. It extends superiorly and inferiorly from T12, L1, all the way down to L4-5. There's also noted significant severe spinal stenosis and compression towards the right side. After seeing us in clinic, we got further imaging in the form of a CT lumbar spine. And again, axial and sagittal views shows that large lytic lesion at L1, destruction of the cortical bone anteriorly, and it extends out to the pedicle, left lateral mass and transverse process. Yep. So again, he is intact on his exam, just complaining of significant low back pain radiating to his bilateral lower extremities. This lesion is likely consistent with a mass. There were some lesions that were noted on his pan scan in his liver, and so we're concerned for possible malignancy in this setting. So based off of history and physical exam as well as the imaging, brings them to a SIN score of a 10 of indeterminate management. And summary, 54-year-old male, progressive low back pain, bilateral extremity with the L1 pathologic fracture, concerning for malignancy. He did have a full MRI of his neural axis, brain, cervical, and thoracic, which was negative, and the Hounsfield unit was average of a 117. So I'd like to pause here briefly for the audience or Dr. Madhavan for further discussion.
Did he have a CT chest, abdomen, pelvis to find out if there is any other lesion other than the liver?
He did have a chest, abdomen, and pelvis CT. There was nothing focal. There was some mild lesions noted in the liver. And based off of his history of alcoholic cirrhosis and this new mass lesion, we were concerned that this could potentially be malignancy.
Yeah, I think it is, most likely I'm leaning towards that as well. So the first thing I would do is probably do a biopsy to see what kind of lesion it is, because once I have a pathology, then I can determine whether it could be, given that the patient is neurologically intact, I would first start with something small to see if this lesion is like, I cannot for sure say if it is lymphoma or any other lesion that could be, radiosensitive. And if I can determine that, and if I can just treat him with radiation, that would be the best approach to begin with. If it is not radiosensitive, then we'll have to do a little more aggressive approach for this with surgery.
So thanks for being here, first of all. Great to hear your voice again. We all live and work increasingly with scores and attempts at trying to algorithmically go through things, and there's a lot of merit to that. But when we look at this patient, first of all, going back to the initial slide, there's a host of comorbidities there, and the spine is like a receptacle of comorbidities. Where are we with having an overall kind of a health score in these patients? I mean, there's a bunch of stuff here connected and interconnected, but that profoundly probably influenced the onset of this disease, presuming that there is a hepatoma maybe component in there, and also the outlook as well as the perioperative risk factor. So where are we with scoring a patient's general health in these polymorbid patients?
So for these patients, especially, it depends on the ASA scoring, and especially the patient has thrombocytopenia, and
Yes.
we make it a pretty significant risk for the surgery. So initially, my goal is to kind of avoid surgery to begin with, unless I'm sure that this cannot be treated with something else. And that's how I usually approach most of the oncology patients. And there is definitely a neurological compromise, but if it is radiosensitive, it can still be managed while the patient is neurologically intact.
So then my next question to you is, there's, again, I don't know whether you follow the NOMS criteria or what, but the amount of neural compromise here is pretty profound.
Yes.
This patient's actually pretty unhappy despite being on steroids. Biopsies nowadays are not a matter of a 12-hour or 6-hour return of information. They are measured in days, if not a week. We have a patient 2 weeks out where we still don't know what they're actually thinking, and it's not laziness, they just know too much and assess too much. So how does timeliness of a biopsy response, short of differentiating round cell diseases from solid organ tumors, help us these days when we kind of have a really compromised neural axis, without paralysis yet, but very compromised?
That's a very good point, Dr. Chapman. And given that if we have to proceed with a surgical option, I would think of one of the two things. One of them is, once again, based on the nature of the disease and so forth, to see if the patient can, if I am approaching with surgery, if I can just do a separation surgery and just get the patient over to the radiation, versus do I need to take the whole tumor out, more like a sarcomatous kind of an approach where you take as much tumor out as possible and have a clean surrounding, and then place um, an interbody or a corpectomy cage there. And if I had to do the simpler form, I would probably go in there and debulk it and just make sure all the neural elements are free of any compression, and then place about screws at 2 levels above and 2 levels below, just to make sure that I'm not completely destabilizing. And the way I mostly see most of these oncology patients is whether the lesion involves the 2 columns or 1 column. And in this case, it appears to be both in the posterior column and the middle column. So I would probably, once I debulk it, I would put in screws 2 level above and 2 level below and stabilize it. If I have an option to use a carbon fiber screw, I would definitely use it. If not, I would just use the regular titanium screws and proceed from there. On the other hand, if it is something that is the only lesion in the body, and obviously there is something in the liver, but if that is the only lesion and I have to take completely out, then I would probably approach with probably doing a corpectomy, either posterior or lateral, depending on where the diaphragm is and so forth. And if the diaphragm is kind of overlapping L1 a lot, then I would probably go posteriorly. If not, I would just do it laterally, which reduces significantly and do perc screws with a very focal decompression from the back.
Okay.
So we'll go into what happened next, and these are all great comments. I want to just shout out to a couple of dear friends. Dr. Dave Pauly, great to have you on board. And congratulations also to Dr. Tariq Sohail from Lahore. Congratulations on a very nice Pakistan Spine Society collaboration with NAS. I was honored to be part of that. And your work in Pakistan and beyond is really cool. So missed you at the Global Spine Congress, but shout out to 2 of the many people from around the world. All right, take us further, Cliff.
So we then proceeded with a staged surgery. Stage 1 was approaching it posteriorly. Again, proceeding with the laminectomy, decompression, and a posterior corpectomy at L1 of the vertebral body there. We did send frozen pathology as well as samples from the vertebral body as well as left paraspinal musculature. During the resection, the tumor was noted to be hypervascular. And so as you did note, patient was thrombocytopenic, platelets was given peri-procedurally, but the tumor was still quite bloody. We continued to proceed with stable fixation, again from T11 down to L2, and with a half corpectomy at L1, and then placing crosslinks, we then finalized the construct. This is just the immediate postoperative imaging, just with a stable posterior instrumentation as well as cement augmentation at the level above and below. Then we proceeded with stage 2. Prior to stage 2, we asked our neurovascular colleagues, interventional colleagues, to proceed with spinal angiogram and embolization, and they were able to successfully embolize the left L1 feeder to the vertebral body using onyx, and then proceeded with the lateral approach for a full L1 corpectomy with placement of a cage at said level. And this part of the procedure went fairly well without any significant bleeding, and we're very thankful that the embolization was able to help with that as well. And then again, this is the immediate postoperative films with very good cage placement in the space of L1.
I do want to point out that there was cement leakage. There was cement leakage. We augmented these screws in open techniques, so not through perforated screws to decrease pressure. So there's a low pressure insufflation despite that. And this goes into what's going to happen next. The bone was surprisingly osteoporotic, and there was leakage, fortunately, without any neurologic adverse event.
So as Dr. Chapman noted, in his immediate postoperative period, about 2 days after the second stage surgery, after aggressive mobilization with PT, patient and his family members noted he had complained of new severe back pain. Repeat CT imaging was then performed and noted to have a new L2 burst fracture with significant cage displacement, and then as well as the L2 screws were pulled out. And so, and frozen pathology was consistent with metastatic disease in the form of hepatocellular carcinoma.
So this, I take full responsibility for this short segment fixation, and again, the surgical decision-making process was a careful one. Looking back at that, we're now dealing with a complication, and so with the benefit of hindsight, Dr. Madhavan, would you have done something differently? Would this have been a patient who you just radiated, now knowing that this is hepatocellular carcinoma? I should point out that this man is a very large man also, so I don't know what his BMI was, but I thought it was 40. Yeah, 40. Yeah, but that was my memory. So benefit of hindsight, back front surgery, after careful staging, palliative care consult, which we do almost routinely for oncologic patients. What should we have done differently? Just radiation, wait and see?
For this one, I would still do the surgery, and the only thing I consider when I'm doing a burst fracture, not just an oncological patient, in a burst fracture, when I'm putting in the pedicle screw, and as you put in the gear shift, if it is going in very easily, like an osteoporotic bone, I usually go 3 above and 3 below, and that is something. And you guys have already done the cement augmentation, which is very useful. And that would be the only thing that I would change. And I like corpectomies. It makes a spine surgeon feel great after that case. But the only thing is now the patient has to make bone at a much longer distance as compared to not having a corpectomy. So I usually debulk it. And in this case, because the patient was osteoporotic, I may have gone like 2 above, 2 below. But the goal when I do that is to make sure that I have enough of instrumentation above and below so that the weight can be transmitted through the instrumentation rather than, across the lesion. And basically this patient does not have an anterior and middle column support a lot. So with the osteoporotic patient, I could have considered 3 above, 3 below, but in hindsight, we can all be right. But during the surgery, I think what you guys did is fairly reasonable. And you had already augmented with cement.
Rod, how easy is it for you when you have Onyx in there to do Rod is a master of far lateral surgery and has developed some of the key techniques. How easy is it for you to do a far lateral surgery after an embolization? Does it make a big difference? And this Onyx, which is an interesting biomaterial, a easy medium to cross through.
Oh yeah, I mean, we definitely have done a lot of these cases. And I think embolization helps a lot. Obviously, I mean, usually what ends up happening is you can actually see the vessel. Yeah. And then, you can clearly see where it's embolized, but it helps a lot. I mean, with some of the, like in this case, this was a very bloody tumor.
And it helped.
Extremely helpful, so.
So you don't have sparks flying? You don't have sparks flying with Onyx or something like that?
No. I mean, if you bovie right over the Onyx, yeah, for sure, you'll get some sparks, but it's not too bad.
Okay. All right.
So then we proceeded with the revision surgery, both stages, posteriorly first, and then we did a revision lateral surgery, full L1, full L2 corpectomy this time with a larger cage in that L1-2 space. And as you mentioned, again, going further below without posterior fixation. So now it goes down all the way to L4. So final stage would be, again, lateral L1 corpectomy with posterior instrumentation from T11 to L4. And again, we have a great placement of the cage in this setting as well. Patient did quite well postoperatively, was discharged from the hospital about 10 days after the second stage surgery, then followed up with a radiation oncologist for treatment of his spine lesion 1 month postoperatively, and then 2 months later, proceeded with immunotherapy for his hepatocellular disease. He remained stable, and this is his 6 months standing Scully films. And again, patient has, kind of returned back to normal function, and his pain is well controlled now.
So Rod, this is, how hard was it for you? I'm sure you cussed me for going short and having to revise this patient, but how hard was it for you to fish out the old cage and put a new, longer cage in, and how much muscle disruption is there to do that?
Honestly, it was really easy. I mean, I think it was both. I think I probably could have done a better job with the corpectomy in the beginning. But I think, with these cases, the bone quality is not always the greatest. And so, and I think Jens, you and I have done a lot of these where we've done a ton of short segment fixations and they do fine.
Yeah.
So I would say this is, it's not unusual, but it's not the common, we've done a ton of one level above, one level below, so.
In retrospect, aside from the large body mass and the osteoporosis, Dr. Madhavan, there was also probably tumor infiltration that I had underappreciated, even in retrospect, at that caudal anchoring site.
Yeah.
So that vertebra literally just disintegrated. When we sent it off for biopsy, it had tumor infiltration in there. I didn't see that. Maybe I saw it a little bit in retrospect, and that vertebra on CT. The MRI was kind of not helpful. So you got your wish, you got a 3 above, kind of a compromise wish, 3 above, 2 below. And the cage is still tilting a little bit. So you're going to talk about pre-Psoas approach. How easy is it, how important is it to have a perfectly aligned cage to have the best possible stress transfer of the anterior column?
As far as the cage is concerned, I do most of my cages slightly lateral. Like for oncology, it's a little bit different. You take as much bone as possible. But for me, as a more of degenerative spine surgeon, I keep the cage a little bit towards one side than the other. I leave at least some amount of patient's own bone there, which acts as an autograft. And I have never had any subsidence as long as the bone is fairly good quality. And in this one, based on the CT, it was really hard to guess that there was any infiltration in the level below. And I have had cages move and settle down a little bit, and they are a little bit angled. They don't look the perfect textbook pictures, and they still continue to transmit the weight across them. And supplanting with the screws above and below, they are the other form of supplanting the weight from the upper body to the lower body.
So Cliff has, I think, a research project that we've done at SSF that he'll finish this case with, and then we'll move on to 3 more cases.
Yeah, so I'll just present this briefly in the sake of time. Again, with our great relationship with Bochum, our colleagues from Bochum, the previous research fellow, Dr. Gerrit Lewick, had conducted this project, and he wanted to study the relationship of vital organs at the thoracolumbar junction, proceeding with the far lateral approach T12 corpectomy model. So I don't know if you visited our center here before. We have a great bioskills lab, and in the lab, we worked with fresh frozen cadavers, and our goal of the project was to assess the spatial relationships as well as the proximity of key vascular structures with this approach, doing a corpectomy, and assess the safety of, and feasibility of being able to do this project. And so just for the sake of time, again, these are just some illustrative pictures documenting us doing the approach in one of our fresh frozen cadavers. This is the placement of the corpectomy cage. Thank you for industry for helping us support this, as well as the intraoperative films procedure. Afterwards, we flipped the patient supine and did a ciliotomy and a median sternotomy approach to pay closer attention of which structures were violated. And these are just some of the images from the study itself. And again, here you see the cage as well as some of the relevant structures. And again, we see the diaphragm, the pleura here intact. It's hard to see on this large screen here, but we also able to visualize the aorta. And in the study, one of the things we noted, there was a defect in the parietal pleura, which is not uncommon in live patients when we do these procedures intraoperatively. And then I guess these were some of the measurements. And again, in summary, just some representative images. There were no injuries to the neurovascular bundle in any of the cadavers. There were no diaphragmatic injuries. The only thing to note, the parietal pleura was violated. We had great preservation of the nerve root bundles at the adjacent levels at T1 and L1, and no injuries to the aorta, hemizygous, or thoracic duct. Currently, the project is under review with one of our journals.
And Dr. Pauly wisely immediately asked, did you look at the thoracic duct? Yes.
Yes.
That was specifically identified as a much overlooked, complicating structure. What impressed me was by design, this T12 complete corpectomy model was done by our fellows, not out of neglect, but they received an instruction of how to do it, and they did this. And so these results were done to show how education, how safe it is to do this kind of invasive-looking complex surgery at the junction of two organ spheres, the upper and the lower torso. I was very impressed. There were literally no injuries outside of the expected parietal pleura, right?
Yeah, and one of the things, as you noted, Dr. Madhavan, we were able to note in the fresh frozen cadavers the extension of the diaphragmatic insertions all the way down to the L2-3 disc space. And so that was another feature that we were able to present in this project.
Yeah, this dome-like anatomy is poorly understood, and again, the diaphragm actually does not insert at T12 or L1, but at L2.
L2-3 disc space.
Yeah, L2-3 disc space. So that's a newer diagram that we created.
Yep, okay.
Thank you, Cliff. Any commentary from your end whilst we're getting Dr. Anderson ready? Dr. Madhavan?
I had a quick question for the previous case that you guys did. Did you have to take down the thoracic 12 rib to put the corpectomy cage?
Say it again. What do we have to take down?
The thoracic rib. No, we just went just below it.
Actually, we took out a segment of the thoracic rib, right? That was part of the
In
design.
the cadaver model.
In the cadaver
Yeah.
model.
But not in the
But not in that case, no.
Yeah, in the case, no.
Okay. Because there was a time when I had taken down the thoracic 12 rib to put a L1 corpectomy cage, and I had entered the thoracic cavity but not breached the pleura. That was something that I always keep on the back of my mind.
All right. Dr. Anderson.
Yeah, hey, good morning. I have a quick case to present. There's a 65-year-old male with a history of L1-2 osteodiscitis and a left psoas abscess that was culture positive for tuberculosis. And he's got months of progressive low back pain. He can no longer walk due to his back pain. He's bedbound, and he has weakness in his lower extremities, as you can see on our motor score to the right. He, in the very recent history, has had multiple procedures. About 5 months ago, he had an L2 kyphoplasty for what at the time was thought to be just a routine osteoporotic compression fracture. And then after that, approximately 3 months ago, he had a left psoas abscess, and at that time the cultures were obtained, and it was found to be tuberculosis. Drain was left, and he was treated with 4-drug therapy. And then after that, about 2 months ago, due to significant weakness and also epidural abscess, he underwent a 1-2 laminectomy with IND. His exam is, he has intact bowel and bladder. He's 3 out of 5 to 4 out of 5 throughout. A lot of his upper extremity stuff is more mechanical. He has some numbness in the lower extremities. His BMI shows that he's obese. He's got a history of type 2 diabetes that is modestly controlled. He's on hemodialysis for chronic kidney disease, and he's got hypertension. And this is a sagittal and axial bone cut window of his lumbar CT. And you can see a destructive lesion at L1, L2. You can see cement, what looks to be in like the L1-2 disc space, and also laterally in the left psoas with a drain that you can see that's right there. Otherwise, you don't see any infiltration into the surrounding bone, T12 or L3 below. And then I have, go ahead.
You go first.
I was just going to say I have a MR, same cuts, stir weighted on the left, and axial T2 on the right, and it shows the edema in those two bones. It shows some degree of stenosis there, despite the laminectomy being present, and no stenosis distally.
So two quick comments. Sorry for the interruption, Brian. Number one, kyphoplasties, this is not done by our service or authorized by us.
Correct.
This was done by another entity. And again, who should do those, who should indicate those, and whether biopsies are taken routinely or not is an unresolved issue. And this was, again, a case where some of those principles were probably not violated. There was not a multi-specialty input with spine surgery in the decision-making, and we are not aware of any biopsy having been taken. So this was futile. We just came back, and Dr. Madhavan, from Bangkok, from the Global Spine Congress, and I'm always impressed. I love this Global Spine Congress meeting. We had colleagues from, for instance, Bangladesh showing very impressive results with TB management, with far less surgeries being done on a large-scale population. What are we doing wrong in the West? We obviously don't have it as much. We get it a fair bit here in the West Coast, but what are we doing wrong? Are we overthinking it? Are we over-applying surgical principles? Are there different standards of outcomes determination? What's the difference?
Well, the thing is, a lot of times when you look at the Far East, they do have far less resources to begin with. And a lot of these patients have to pay by hand, like there's no insurance that covers them or something. So the surgeons are used to doing it with the least amount of resources possible. And when they have done that, they gain a lot more experience, and they know at what point I have seen cases like this where they have just went in laterally and even put like a small autograft, like a iliac crest autograft, and debride it, and then put two levels above and 2 levels below, and the bone has completely healed. And in here, what I feel is we have a lot more resources available on hand, and we usually don't think a lot about the natural healing abilities of the spine to some extent. And the second thing is, we also are a little bit scared of the lawsuits and things like that, because if I go in there and just debride that and maybe put an iliac crest autograft and put 2 level screws above and 2 level below, and let's say it collapses or something wrong happens, then you can easily be sued. And there will be a lot of spine surgeons who will say, I will do a corpectomy, which will provide a lot more support, and and that's what spine surgeons, they try to do everything possible to accomplish this in a very objective fashion that nobody would be able to actually even point fingers. As far as this one is concerned, I would still do the same thing, where I was thinking of just going in there laterally, debriding, because going posteriorly, the patient already had a laminectomy, and there's going to be a lot of adhesions and so forth. So, and the other thing is the patient is kyphosing at that particular level. So I would go back in there and then try to see if I can get a very nice iliac crest autograft. And after debriding that area and also taking out the cement piece, I would put in a tricortical iliac crest bone graft, and then place 2 screws above, 2 screws below. And based on the MRI, if there is some compression there, I would do a small laminectomy, but the screw placement would be percutaneous. And the other thing is with the TB, because it is such a chronic infection, once it breaks through the skin, it continues to drain for a long time. So I want to minimize that as much as possible, keeping the wound as small as possible. And laterally, it is totally unheard of about a non-healing wound, but posteriorly, yes, it is possible. So I would keep a very small focal laminectomy because the patient is 4x5 strength in the legs, and there is a compression noted on the MRI. And other than that, I would not put in any cage or anything like that, and definitely remove the cement.
And the iliac crest graft, is that an autograft that you'd put in there? Because this is, then basically there's like of 2 vertebral bodies, there's like 70% total height. We can probably agree on that number or more gone. So this would be like a hemipelvectomy, or am I catastrophizing here? What kind of a graft length do you estimate having to put in there?
That's a good question. because a lot of times, if I'm not able to get a very good graft, I would put an allograft of iliac crest rather than putting in a metal.
Got it. All right, Brian, take us forward. What did we do? Drum roll.
Yeah. So we did stage the procedure. We started out posteriorly. We did a T10 to L5 instrumentation with fusion. We revised the laminectomy that was previously done at 1-2, and then we did a posterior debridement from the backside. And then about 6 days later, we came back from the lateral position, and we did a left-sided approach where we debrided that psoas, removed the cement that had extruded into the psoas area, completed an L1-2 corpectomy, and then we placed a cage. Otherwise, the procedure wasn't complicated. Blood loss was reasonable. And here you can see CT sagittal, coronal, and axial, showing the final construct with the cage placement, with some improvement of the kyphosis and height at that level.
And for every infection, one thing I do, which I picked up from some of the general surgery colleagues, is a combination of betadine and peroxide washout, followed by Iricept washout. And I do this 3 times of each. It is just for my satisfaction. I don't know if there is no paper that says you can do 2 versus 3, but I just feel good, like once I wash it out. And then as far as there is that stimulant beads, I haven't done a TB recently in my practice, but stimulant beads has a good number of antibiotics that can be added. I don't know if rifampin is one of them or not, but if that is an option, then I would definitely put it around that area to minimize local spread.
So Rod,
Yeah.
how do you do this? So this looks nice.
Yeah.
Do you do anteriorly first and then posterior first to realign? Tell us a little bit about your surgical sequencing. And you obviously listened to Dr. Madhavan's lecture of 3 above, 3 below.
Yeah, well, I mean, this guy actually did have a non-healing wound, and he was bedbound, and he had neurologically deteriorated, so he kind of got sent down urgently. His wife is actually one of the ICU nurses, he had excellent, care. I think he just kyphosed after the laminectomy and just started getting worse, and the abscess got bigger. We didn't know it was TB, I think, until like maybe that night before we did surgery. And so, they had really didn't, they had sent some cultures, but they really hadn't done a good job of like trying to figure out what the infection was. So that made it challenging. He just poor nutrition, diabetic, medically very complicated, so he staged it. And I was worried that he was going to get an infection, post-op. And fortunately, he hasn't. The only thing he hasn't done, which you can see here, he's got some pseudoarthrosis, and you can see the cage hasn't really, totally incorporated. He's got some halos down below, but right now, like, I'm not touching him because he's actually doing fine. He's got no symptoms, but you can see he's got haloing around the L5.
Yeah.
So.
This is one of those things, when I hear about posterior percutaneous screws and long constructs, that's basically not going to heal, right?
Yeah.
So what are your thoughts on that?
Yeah,
When you hear posterior percutaneous multi-level fixation?
Again, I try to, we burn the facets out to try to get a fusion, but it's really difficult to get, if you're doing percutaneous, to get the posterolateral fusion. So you're really relying on the facet joint. And then in this case, we put, in TB cases I've done, usually it fuses like mad after surgery, but this guy's just, I think he's just got horrific, protoplasm. So, but he's done well.
So one of the things I wanted to add for the posterior percutaneous screw was, whenever I have done a multi-level construct, I have tried to use a very small piece of BMP. For example, use a small BMP and cut into 6 pieces or 12 pieces. And then I tied right with a Vicryl at the bottom end of the tulip of the screw. And when I go in there, obviously all the percutaneous I'm doing either with a robot or navigated now. I go in with a navigated drill, burr the facet, and then put in the screw, which has the BMP right below the tulip. So what I've seen is like there is the facet joint, then there is a BMP, and then there is a screw. And that has helped me to some extent achieve a posterior lateral fusion. And I also inject some amount of some amount of DBM around that each per screw. And that is something I have been doing for quite some time. And I don't know that Dr. Oskolian or Dr. Chapman's thoughts about it.
BMP.
Yeah,
I mean, I
BMP,
think
yeah.
BMP is definitely, I use it a lot in cases where, I'm worried about a fusion. And I've used it in infections. I mean, I know it's off label, but, I think in his case, I probably should have used it.
Yeah,
So,
it actually makes total sense to use BMP in infection patients. It's off-label, off-label, off-label. Just want to make that very clear. Steve Garfin wrote a great paper about that, which is a clinical series. So not the highest level of evidence, but empirically it makes sense and practically it makes sense. So yes, the attempt at trying to get a fusion with posterior percutaneous screws is again still something in a state of evolution. Personally, I'm always very suspicious when I see percutaneous screws at multiple levels because usually there's a predictable non-union, but I don't want to poo-poo it. There's some benefits also. Quick question from Dr. John Jungheim. TB drugs and PMMA. So we all now know that PMMA is actually a great carrier for certain heat-resistant antibiotics like vancomycin and tobramycin. Any anti-TB drugs, I think you mentioned that a little bit, Dr. Madhavan, that you can think of that could be put into PMMA?
I have only used vancomycin with PMMA. I haven't done any other things. And this is one of the patients, we had to just use PMMA more rather than like actual cement. We just had to, there were like significant screw loosening on a patient and haloing, and we just had to cover that up after we removed the screws. And we used PMMA with vancomycin for that. But other than that, I haven't used it as a rifampin. I wanted to look into that now that we are discussing this. After this thing, I'm going to look into what other TB medication that can be mixed with it.
Dr. Jungheim, we'll have to get back to you on that because I don't know the answer either. Great question. Dr. D3, Dr. D. David Davis III is going to talk next. Internationally renowned. And at Bull Spine Congress, we had a participant come to us and go like, where's D3? He was here home minding the shop with Dr. Abdul Jabbar. So D3 is going to present a case.
All right, here we go. So this patient was an approximately 65-year-old female who was from a remote location and came in with a history of multiple falls, one of which was particularly bad a few months prior to presentation. Most of her pain was located in her legs. She did have a complicated medical history of being a smoker, type 2 diabetic, and then apparent metabolic syndrome. On physical exam, she had pain-related weakness, and particularly in her hip flexors bilaterally. And you can see more closely into standing x-rays, you can see a type A4 burst fracture located at L3. An MRI was obtained. There wasn't significant neural element compromise. And then a CT scan shows a mild coronal deformity as well as the extent of the bony injury. So at this point,
So here we're moving down the spine. We're down the mid-lumbar spine to lower lumbar spine, osteopenia, degenerative things, a mishmash of things. Patient has failed appropriate non-operative care, surgeon supervised over, I think, half a year or more. Bone health optimization was attempted. Not sure how successful it was. Where do we go now, Dr. Madhavan? If you go back to the last image that you have. Role of
metabolic syndrome that you mentioned there. I didn't get that. What was the metabolic syndrome?
I think the usual conundrum of diabetes.
Yeah, we've had a few discussions about metabolic syndrome. It's a broad array. She meets a couple criteria. The osteopenia and diabetes meet criteria.
Pulmonary hypertension, polyarthralgias.
BMI.
The BMI is obviously elevated, well above 35, I think 38, 9, something like that, maybe 40.
Pretty significant sarcopenia here.
Sarcopenia, yeah, that's part of it. Look at the psoas
Gotham
shadow,
too.
no psoas. So thoughts?
Where is the, what is the distribution of the pain for her? Is it entirely in the back or did she have any leg pain?
Her pain is mostly in her legs, but when we, I do only have a single slice here of our MRI, but
Is there any specific distribution for the leg pain?
no, it was mostly down. I think we noted lateral thigh.
Lateral thigh.
It seemed nonspecific.
Okay. She didn't have any specific pain correlating to L5 or S1 nerve root, right?
I did not pick up on that. We've got our Asian motor tables here. It seemed to be, from a motor deficit, it seemed to be pretty diffuse.
Okay.
Great questions. Again, we get into this conundrum of general disability and non-monoradicular problems. So disuse and some neurogenic claudication elements. The main question is obviously we have a deficient anterior column. We have a very poorly maintained caudal foundation in terms of the motion segments. They're in end-stage spondylosis with some degree of foraminal stenosis. Do we intervene surgically? If so, how high, how low, where do we go?
So definitely L3 needs to be at rest because it's almost completely compressed. And so I would approach it laterally, and the psoas on this MRI picture appears to be fairly small. I always approach from the left side. I could easily remove significant amount of the body and just put in a cage and expand it intraoperatively and see how the alignment looks and so forth. And then I would do that as a stage 1 and see how the patient does after the surgery. And on a day 3, I would obviously do a CT scan and then have the patient get up and walk. And I would reassess the symptoms a little bit to understand what should be my extent of posterior approach there. And, if I had a confirmation of that she is symptomatic from L5 and S1, then I would also add a lateral approach to L5 and maybe an anterior approach or maybe not. I'm not completely sure right now. Definitely I can approach a L4-5 because also looking at the CT scan, the crest is fairly low, so I can easily approach L4-5 as well. So I would do a carpectomy and a L4-5 lateral approach. And then from the posterior, the only thing I would figure out is now coming to the last segment at L5-S1, if she has any issues there or not. If she does not, then I would put a percutaneous screw placement all the way down to pelvis. And if she has symptoms there, or if it is unilateral or something, either I would do a microdiscectomy on that particular side or a small focal laminectomy. And I would still go from probably 2 above and 2 below would stop at L5. So in this particular case, L5-S1 is degenerated. I would go to S1 or pelvis.
Thank you.
All right.
I'm going above L1, L2. Anytime I go above L2, I try to go up to the pelvis because within the first 6 weeks to 12 weeks, I see them coming back with SI joint pain.
No, thank you. Appreciate that perspective. In this case, we decided to do a stage surgery. So stage 1 was a T9 to pelvis from a posterior approach. We did a intradiscal osteotomy at lumbar 5-1, given the degenerative disc disease that you noted, and then an eccentric cage placement with IDO at L4, L5. And this helped us to restore her balance. And I just included this to show our eccentric cage and our restoration of coronal alignment despite the slightly off-axis CT scan that was obtained. And then stage 2 of the procedure was a L3 corpectomy done from a lateral approach.
Now, Rod, you did a beautiful job yet again with your far lateral trans-psoas approach. Dr. Madhavan said something interesting. He always goes from the left side. Do you do the same thing, and why?
Yeah, I mean, I tend to go from the left. I just feel more comfortable, if I have it's much easier to deal with a venous injury. Vascular complications are more manageable, I think, from the left side. And it's just the way I set them up for the OR. Sure. Then the team knows it's always left side up. But, I mean, you could go from the right, so.
Dr. Madhavan, why did you say that you're going from the left?
And that's a same thing. I feel the corridor is much bigger between the aorta and the anterior aspect of the psoas, and it makes it much easier. And if there is any issue with the aorta, it's much easier to repair. And aorta, the wall is pretty big and very thick and strong, and it is very unlikely that I would injure an aorta. And I have seen aortic injury when we did a sympathectomy during my medical school days. And I have seen it was a general surgeon. He had a small nick on the aorta. There was a lot of blood that was coming out. He immediately put a lap, stopped it, and waited for a few minutes, and then immediately closed it with a small Prolene stitch. And the way he dealt with it was so eloquent and so nice that I always felt like, I could repair that. And in the past, when I have done an ALIF or something, I have injured the iliac vein, and it's really difficult to close. And I have always called a vascular guy most of the times. It has happened about 3 times, but it's a very tiny tear, but it's still very difficult to close because the valve is so friable.
A question from Dr. Farzan Farkbash, and I'll ask you, Dr. Madhavan, to address that maybe. Was it really necessary to replace that anterior column with a cage? Could we have just done everything from posterior, maybe realigned the spine 4-5-5-1 to assure foraminal patency and realignment? But was it necessary to put a cage into L3?
That's a good question. We could always get away from not doing it if you have enough fixation above and below. The reason I would put it in is anterior column support. The second one is that the patient is osteoporotic with the metabolic syndrome, and any screws with a significant loss of anterior column support tends to become loose, and you'll start to see lucency around it and so forth, and you eventually end up doing it. And I have had that done in the past for a couple of my cases, and since then I have learned the lesson to not try doing that.
And I agree with that. And the lateral approach allows for far bigger footprint of the cage end plates to the vertebra. And Rod did a beautiful job. And we can talk about far lateral versus anterolateral. Well, I want to finish with Dr. Neil Patel last, but certainly not least. He was in the OR with me until the wee morning hours, and he looks great. So Neil, what case do you have?
All right. Hey, Karthik. Thank you for all your support throughout the years and taking care of my family friends. So,
yeah, thank you, man.
We have a 68-year-old male who presented with progressive back pain, severe couple of weeks of difficulty urinating, and had history of anemia and chronic back pain, and that's all he had. Intact on exam. When he came to us from outside hospital, he had this MRI, and I'll show you a video later, but MSSA bacteriuria was his diagnosis, and he also had no MSSA in the blood, but definitely had elbow bursitis from that as well. So this is the MRI image that he presented with. I have a post-contrast scans after this, but the T2s, axial and sagittal and STIR images definitely show some erosion of the disc at 2-3 with severe compression of nerve roots. And then cranial to that, there's some stenosis as well, probably coming from epidural disease. This is his post-con MRI. And again, severe disc erosion, kyphosis, a little bit of kyphosis, subsidence. And you can now start to see psoas abscesses as well. Left side is pretty big. CT scan showing, again, erosion of the vertebral body, 2 and 3. And he's trying to heal. So Dr. Chapman always says there's bone formers and non-formers. So he seems to be a former. That's good.
He would like to heal.
He would like to.
There's instability and some microorganisms that's standing in the way. So is there, again, we've talked about infections before. This is a suppurative disease, right? So
Right.
What was the organism again?
MSSA.
MSSA. So run-of-the-mill MSSA, nothing exotic here. Multi-level spine disease, again, a polymorbid patient. this time lower lumbar spine, this time a exuberant bone growth. I personally have really shied away from going anterior or laterally in these infection patients. Dr. Madhavan, Dr. Oskuyan, how difficult is it to get down in this inflammatory hyperreactive zone to an anterior debridement and column reconstruction?
I totally agree with Dr. Chapman. And as far as this one is concerned, I would just go from the posterior everything, because a lot of times you see that I approach from the left and there is a big psoas abscess on the left side, and there is significant amount of adhesion probably on the way trying to get in. So I would probably have the general surgery or somebody put in either a pigtail or something to drain that abscess and try some amount of antibiotics before I get in there, and at least a few weeks, once that appears to be more healing, or like, the abscess have resolved, then I would still approach from the posteriorly and just put in an iliac crest. Small graft is fine as well. And I saw that the pedicle was preserved for both the levels that has infection. I would put in a very small pedicle screw, like maybe 30 millimeter tall pedicle screw at those two levels, and then still fuse probably 2 above and 2 below, because it appears to be, patient appears to be very osteoporotic. And I would definitely implant something like a stimulant beads and wash it out with Iricept and a peroxide and betadine combination, all posterior. This particular one, I'm not very confident of going in from the left with the psoas abscess on the way in.
All right, take us to the conclusion here, because we're running out of time. Sorry, Neil,
Okay.
rushing you.
That's okay.
Great
So we
preparation.
did stage 1, posterior T10 to pelvis, stabilize him, and we did do a little bit of corpectomy, at posterior corpectomy at those 2 levels, 2 and 3. Going through that. We then staged him for anterior. We did prone trans-Psoas approach. There was some venous bleeding encountered during the case. So we did stop and got a CT scan that shows our hemostatic agents within the psoas. We already talked about that this may be a little bit difficult left-sided approach right there. We took him back again because there was no other issues. This time we were able to get a cage in, and like all good patients, he was lost to follow-up.
So we'll ignore that statement, but this was a prone surgery, right? An attempt at a prone corpectomy.
Yeah.
What do you think about this concept of doing a PTP? This has been a great concept now that's emerging, a prone simultaneous trans-psoas surgery.
I have a couple of slides in my presentations on that, and I have done a couple of PTPs and also a couple of lateral A-lifts. The only problem with that is the size of the cage in a PTP is not as big as the size of the cage that I'm going to be using when I place the patient lateral. That's one thing. And the second thing, PTP, most often I have to do it trans-psoas rather than pre-psoas. And for example, if I can avoid going through the muzzle, I would avoid going through the muzzle, and I would rather not injure the psoas, and just do it. If I have to do lateral and posterior, I will try to figure out a way to just do it posterior and try to avoid a PTP, because I feel like PTP is it's a fairly good surgery, but if I'm doing a lateral surgery to achieve a lateral indirect decompression. And if I'm not able to achieve that and still I have to go from the posterior, there is no point in doing 2-step stages. And I feel like, as a surgeon, I'm not looking at the patient as just because I know 2 different ways of approaching this. I don't want to approach it 2 different ways and try to do it 1 stage and get it done.
Good stuff. Thank you to our fellows for their presentations. Great presentations by all 4, and hopefully this whetted everybody's appetite as to the potential, the controversies, and the outlook for anterior column reconstruction using modern techniques. A lot has happened in that field, and having bright young stars in the field like our visiting guest lecturer, Dr. Karthik Madhavan, is a great thing. He's a graduate of the University of Miami, and he has won several awards in both AANS and NAS. Of particular personal meaning to me is the Kuntz Award. Charlie Kuntz was a former fellow of mine, and so he's one of the bright young stars of the 20 under 40 award from NAS. Again, really curious and thought-provoking discussion here, but curious to hear your thoughts on where to go with anterior column reconstruction using less invasive anterior and anterolateral techniques. Thank you for joining us this morning from New Jersey, Dr. Madhavan.
Thank you very much for the opportunity, and I'm going to start sharing my screen. Can you see?
Looks great.
Okay, thank you very much. Just going to go on the presentation mode. I think Dr. Chapman told me this is in 2020 when I graduated, and I have about 50 papers, and have done a lot of talks and a lot of symposiums. And Charles Kuntz Award, I'm very happy to receive it twice, both as unfortunately as a second author, and Stuart Dunsker Award was one of my favorite as well. And I review for almost every journal in spine. And I review about like probably 10 to 12 papers every week. And that I feel has made me a much better surgeon. And I was in Sanford in North Dakota before coming to New Jersey. And that's a private practice. I had to be in an underserved area for 3 years, because I was on a J1 exchange visitor visa. And once I was done, then I moved to New Jersey, more looking for an academic practice. And this was North Dakota, beautiful, beautiful place in summer. And when you get to winter, it gets brutal. And so that was something that I just could not, bear with. And I was looking for an academic practice as well to continue the rest of my practice life. And this is one of my mentors, and I thank him and dedicate this talk to him, because what I learned from him is he was one of the guys who had the most happiest clinic ever. And did he have complication? Yes. And he had the least amount of complication of all the people I have seen. And there are few things that I took from him is an ACDF, ALIF, lateral approach, and Coflex. All of them, he did it so well that during my chief year, soon after I used to finish the cases, with him, I used to go and write down every step that he did. Obviously, we will all have our own modifications, but I'm very thankful to him that helping me learn these techniques, which have translated for me to benefit a lot of patients. And I'm always thankful to Dr. Steve Vanning. And he's in South Florida as the chairman of Nova Southeastern. And if anybody lives there and needs a consultation, he would be a great guy. And Olaf, I'm not, given that I think I have about 30 minutes, I'm not going to go into a lot of different things, concentrate more on the case approaches. Lateral approach evolution, it started in 1908, the first time ever documented. And from 1908 to 1944, nobody even thought of going retroperitoneal, which is a long time. And if you look at the current progress, in the last 20 years, we have come through a lot with the lateral approaches. And the two big names that I have always come across in the early 2010s and late 2000s was Dr. Pimenta and Dr. Juan Uribe, who have popularized it. And we all know that, we all went through the COVID. And I always thought like, the OLIF evolution or the ATP evolution was very similar to a COVID evolution. So the first thing was the retroperitoneal approach in 1908. And then till 2002, there was no significant change in that, although they have attempted it. It was the first time like a virus from an animal jumped to infect a human being, right? So that was a big leap. And then after that, it slowly started to gain some acceptance. And if you look at back in late 2000s or early 2010s and so forth, they always had a debate in these spine meetings, whether open versus MIS. Now they don't have those debates anymore. They have which MIS surgery would you do for this one kind of a debate. And and then they got saturated. Like, for example, when Nike got saturated with just the running shoes, they had to get somebody to jump into another sport. That's how Air Jordan started. And that's how the ALL release was created to attract the deformity guys to the lateral. And then after that, there was a single position surgery. You could still place the screws with either navigation or robot in a single position. That was more like a gamma, still not widespread yet. But then once they started to do the anterior to psoas, that caught up, I feel like, significantly what the number of cases I see as compared to like close to 2020 to now. There's a lot more people who are doing anterior to psoas, and they feel way more comfortable doing it as compared to transpsoas. And then once they came up with the lateral plate where you could just stabilize everything with the ATP, I feel that's more like the Omicron variant, where they were able to jump the hurdle of getting a lot of surgeons to do this MIS only without going posterior. And some of the indications, we have already gone through a lot of them. The third point where I say manage patient expectation is I always believe when we approach a patient, I tell the patient, like, I am also kind of a pain doctor, but, I treat it differently. I treat it with the surgery, but my goal is still to figure out what structure in your back is generating the pain. Whether it is in the back, is it the facet joint? I literally check their back and palpate their spinous processes and go a little bit lateral and palpate their facet joints and so forth to kind of understand where the pain is being generated from. And whenever I say back pain versus leg pain, I always tell the patient if the back pain is the worst pain, it's much easier to treat it with a fusion. But if it is the leg pain that is kind of bad, not too bad, then I tell the patient to manage their expectation that, hey, your back pain will get better, but your leg pain might take few months to get better. If you're okay with that, then we'll do a lateral approach versus a T-lift or something else. And they will obviously tell you which is more tolerable. That's one thing. And the second thing I always tell them is that, there is always a chance that I might have to go from the back to do either a microdiscectomy and so forth after the fusion settles in. And most of the patients say, either I want to do one surgery and be done with it, or somebody will say no, just fix whatever you can laterally with the minimally invasive. If I need the other one, which I don't know if I need it, then I'll come in and get that done. And I always give patients the example, like let's say if you have I used to have a F-150 when I was in Fargo. I always told them, let's say you bring in an F-150 for service, and they tell you that one tire is really bust, the other 3 tires will give you about 5,000 miles. And there are 2 kinds of patients. First one picks up and says like, okay, I'm already here, just change all 4 tires. I can't come back for another 5,000 miles later. And the second type of patient says, no, change the only tire that's bad now. The other 3, I'll come back later. And that also depends on the patient personality. Once you discuss with them, you kind of understand and give relevant examples, they get it almost right away. And saying that, I'll go to the approaches. And the good thing about the pre-psoas approach or the ATP or OLIF is not needing to monitor. You're not going through the substance of the psoas muscle, where most of the nerves are, whether they're on the surface of it or whether they're in the substance of it. You don't have to worry so much about it. And that makes it possible for it to be used in the ASC settings. And I wouldn't do that as a first case, but something to consider in the future. And so this was one of the papers. I'm not going to go through a lot of different papers, but this is one of the papers where they have shown that the pre-psoas has way more interbody space. And what is more important to consider here is on a T-lift versus a lateral. In T-lift, the fusion happens around the cage. In a lateral, the fusion happens through the cage. The bigger the size of the cage you put in and the better end plate contact it has, that really benefits the patient and improves the chances of fusion, because the width of the interbody you have, most of the people who do trans-psoas use a 18 millimeter, and most of them who do pre-psoas or anterior to psoas use either 22 or 26 even, depending on the size of the patient and so forth. And some of the specific things that you encounter at L4-5 is the iliac crest. How do you overcome that? There are once you make sure that there may be the iliac crest that can come in the way, you can either break the bed slightly. And the second thing, you make sure that the implant company has an angled inserter for to overcome the crest. The lumbar plexus, it's not too difficult to overcome. You just avoid it. Iliolumbar vein, this can bleed the patient to death. So be very careful on making sure that there is no, it almost always crosses at the L5 body or the L45 disc. And it may not be ipsilateral. If it is ipsilateral, you can easily put in a stitch around it and cut it. If it is contralaterally, do not use a cob to make the contralateral annulus to open. Use a paddled distractor, or what you want to call a spacer or a distractor, that can be used instead of a cob, because cob is way more sharper than that. And that one, I always hold my hand strongly with probably about like an inch or half an inch above the skin, and then very carefully mallet it in. And even after it goes about few millimeters across from the contralateral disc space annulus, it should be good. And the femoral nerve can definitely be avoided by going pre-psoas. And L3-4, the psoas muscle bulk is the maximum at that level. And so just be careful. And the ureter comes closest to the psoas, but the ureter is distinctively different looking. And I always make sure that during my surgeries, I'm not an abdominal surgeon or a general surgeon. If there is any structure that I do not identify, I preserve it. I don't try to mess with it or anything like that. Sympathetic chain can look like a ligament. It looks very white in color, and it looks like a psoas attachment and things like that. Just be aware of it. You can easily mobilize it. It's not a big deal. And genitofemoral nerve also comes around there. And the best video I would see of Dr. Shane Tubbs. I saw his videos multiple times. And I have benefited with a lot of videos of Seattle Science Foundation, and which is why I wanted to give back, at least in a small way, by doing this presentation. And this is one of the cases for the L23 and L12. You have to watch for the psoas attachment. So as you can see, can you see my cursor on the screen?
Yes.
Okay, so as you can see, if you're coming in like this, there is a, depending on whether the patient, when the patient is intubated, the psoas is pushed down. You can easily enter the thoracic cavity here because the diaphragm doesn't look like a dome anymore. Because it is pushed down, the thoracic cavity can come all the way up to here, right? So that's why when you're going there, if you're not really looking to go straight, be very careful about it. And you could get into the pleural cavity or the thoracic cavity. And once you, it happened to me on a L12 rather than L23, but immediately I saw that there was no damage to the parietal pleura. So I was able to use a long DeBakey to put a stitch into it, which when the hole was this big, I had to make it like almost this small by putting that stitch, and I did not have to put in a chest tube for that patient. And there was no leak as well that was noted, and the end tidal was well preserved. End tidal CO2 was well preserved in this patient. And this is once again the L12, same thing for the rib attachment. And if you are able to break the bed, that really helps to move the 12th rib off. If you plan on going between the 11th and the 12th rib is where you have to be extremely careful about not getting into the thoracic cavity. And as you go closer to the spine, you will see that looks like a muscle, but it's not really a muscle. It is a diaphragm attachment because psoas is almost barely existent at that place. And said that these are the same things. So the one thing I always look at on the MRI is this space here. What is the amount of pre-psoas space that you have between the anterior end of the psoas to the lateral aspect of the aorta? And once I see there is a decent amount of space there, then I choose them for the surgery, and also make sure that on the lateral X-ray, the crest is much lower. And this is I feel is one of the most important slides. As you can see, the two red things here, one of them is the aorta. towards my right side, and the other one is the IVC. IVC can come much closer as well. And as you can see, the corridor here in front of the psoas to the aorta is much bigger. And let's say you pull the psoas back and start here. As long as your hand is, I'll get to how you can avoid going anterior or posterior, is as long as your hand has to be perfectly perpendicular to the long axis of the vertebral body. And once I'm positioning it, obviously the left side up, and the legs, you can either extend it or keep it flexed. If you want to break the bed, it would be easier if you flex the leg a little bit, because you can get some extra skin to pull across, and surgeon always stands in front and the CR posteriorly. And I always prep the patient from bed to bed, end of the table, all the way anteriorly, right here to going all the way back, because during my residency, we had seen an IVC injury. So at that point, they were like, now in addition to the IVC injury, you're going into a non-sterile zone as well. So I always prep from bed to bed, from the anterior end of the bed to all the way to the posterior end of the bed. The posterior end is definitely important if you're putting in the screws in a single position. And on the x-rays, the first x-ray, I feel after you position everything and lock the patient down, then you give the bed control to the anesthesia and tell them, make sure that the patient can roll anteriorly or posteriorly, or airplane the patient anterior or posterior. So the first x-ray I would take is an AP x-ray. And during that AP x-ray, let me go back to this one, I would make sure that the spinous process is almost parallel to the ground. When your spinous process is perfectly parallel to the ground, even if you have scoliosis or anything, this particular vertebral body or this particular disc space is going to be in line with that vertebral body. And when your hand is perpendicular to the ground, that's when you do not lose your orientation of going anterior or posterior. You won't be injuring any vessels here. You won't be injuring any nerves here. And you will be going perfectly down. And this is made sure by my rep. Once I make sure that this spinous process is parallel to the ground, my hand, as I get into the disc space, should be perfectly perpendicular. And that is what my rep always makes sure that at end of the, at the beginning of starting the discectomy. And it is like a pendulum effect. It can, although your starting point might be perfect, and the end point or the projection may not be. So just be careful on that one. And the technique, EMG monitoring, is obviously optional, 5 centimeter anterior to the midpoint of the disc space. The only 2 times I cut use a knife is the skin incision, and the next one is cutting the annulus. Soon as I open the skin incision, then I open the external, internal, and the transversus abdominis. Almost always, like about, I would say 90 to 95% of the times, the transversus abdominis is a muscle and not a fascia where you are making the incision. And once you make an incision, you split all the muscles. And once you split all the muscles using a Penfield 1, it makes it much easier. You don't have to cut any of them. And once you go all the way down, you can use either an endoscopic Kittner or your fingers to push all the fat, which is retroperitoneal, anteriorly, till you find either the quadratus lumborum, which is around where the TP is, or the psoas itself. And most often, if you're going perpendicular to the ground, you encounter the psoas first before the quadratus lumborum. And once you encounter the psoas, follow it medially as till you hit a bone. And once you hit the bone, that's when you start to mobilize the psoas. And in this particular thing, this is the incision where I usually keep the midpoint of the disc space to where the crosshair is here is about 2 inches. And that's where my incision is almost always going to be. If it is L3 to 5, my incision is more this way or right in the middle here. If I'm doing anything higher, I'm going to do much more of a vertical incision. If I'm dealing with more than 3 levels or so forth. And soon as you feel feel the bone, you trace it down above or below, you will see a clear hump where you will encounter the disc space, whether the disc space is collapsed or not. And then once you identify that, you go in with a 15 blade, make a tiny nick in the disc space, place a K-wire and get an X-ray and confirm that level. Once you confirm that level, you put a series of dilator followed by the retractor. I use something called as an OBP retractor. I do not have any conflict of interest with them. It is a lighted handheld retractor. It comes in 135 and 175 length, and it's really been very helpful for me to get when I'm in the retroperitoneal area where just my loop lights are not enough to get all the way down. And soon after that, I put in the carb. And now, soon as I put the carb, I make sure my rep stands at the end of the bed and my hand is perpendicular to the ground. And once I make sure of that, I very carefully mallet it in. And once you touch the contralateral annulus, it'll start to bounce off. Now you got to be very careful. Hold the carb so that it doesn't slip deep down, and just mallet it enough to get the widest part of the carb, which is about 5 millimeters behind the tip, to cross it. Once you cross that, you're good. You don't have to take it out, flip it 180 degrees and go back in there. Just one opening is enough. And after that, I start to use a series of distractor paddles, followed by, if patient has any signs of osteoporosis, I never use the scraper. This is followed by, I use a C-shaped curettes. All the spine companies have it. I usually use that to very carefully scrape off the end plate and the end plate cartilage. And when you pass in either a DeBakey or a Penfield and feel the end plate, it should feel very rough. If there is any sign of smoothness and there is still no disc, that is the end plate cartilage. You have to take it out for the fusion to happen. And in a fusion case, without taking it out, it reduces the chances of fusion significantly. And the same thing at this point, when I'm putting in the cage, I make sure I go to the AP X-ray and make sure that the length of the cage fits in properly. And once you have a good length, you can either, some of the companies have an expandable trial, some of them don't. If you don't have an expandable trial, then you go back and forth between 8, 10, 12. My most common cages that I have put height-wise is 12 or 14. And for that reason, if I'm using an expandable trial, then I open it and it gives you a number. You wait for about 30 seconds for the body to accommodate it, then open it some more. When you're doing that, make sure the contralateral or the distal end of the trial crosses the lateral border of the vertebral body. That minimizes any subsidence or break into the end plate. And once you have that one, you can insert the cage finally, the size that you feel is the right appropriate size and the right fit. And after that, you can put in a plate. It's optional. And I will go through some of the cases that have done standalone. And orthogonal, every time you put in either an implant or the carb, just make sure your hand is perpendicular to the floor, because the long axis of the vertebral body is perpendicular to the floor. And the closure, I very loosely close if there is a transversus abdominis fascia, I close it strongly. You can see here where the transversus abdominis fascia is and where the muscle starts. So if there is a muscle, then I very gently close it with a 0 vicryl. I don't super tight the knot around it. I put it loosely just for it to form a scar tissue so that nothing herniates out from the abdomen. And you do it for every level. And then once you come, there is something called as a very thin external oblique fascia. I close it very tightly with 0 vicryl, followed by subcutaneous tissue and the skin. And that's pretty much for the closure. And this is one of the cases, a 48 BMI patient. Originally had set him up for L4-5 anterior lumbar interbody fusion. And my vascular surgeon said, I just can't do it. It's too much. And so I changed it to a lateral approach. In the meantime, that we called him and told him that the instruments we need to do an anterior would be very large, and we don't have it. And he complained to the hospital saying that we were almost fat shaming him. And that is something to keep in mind. Although we didn't tell him that he was, very large patient, we just mentioned as a BMI thing. like his BMI was very high, but people can be sensitive and something to think about. And he failed all conservative management. And this was his anterior listhesis at lumbar 4-5. And the same thing as well. And you can see on the MRI, his main pain was mostly axial, back pain worse than the leg pain. And we put in a 14 height and a 60 length with 8-degree lordosis on this particular patient with per screws. And he did very well after the surgery. And this is the post-op. And when you're doing cases like this, when there is an anterior listhesis, use your distractor to distract in only one way. So if you're going in, just keep going in one direction where you're trying to bring the L4 body back over L5. That mobilizes it a lot and also gives a good amount of indirect decompression as well. And once you mobilize it, you'll be able to get a good amount of height on the cage that you're trying to put in. And this is the CT scan and pre-op and post-op. And we reduced it to probably like maybe 0.5 spondylolisthesis from 1.5. And every time I do these cases, I tell my rep to make a note of everything I do, every step of it. And he sends me at the end of the day to see where I spend the most amount of time. And I try to figure out if I can improve that in any way in the future and what was the delay in that particular occasion. And this patient, although it took about 3 hours, 51 minutes, the most of the 51 minutes was a retractor placement. Usually for me, it is about 20 to 30 minutes on most of the patients. One more patient, L3 to 5 previous interbody fusion, was on narcotics for quite some time, had a L1 radicular pain and also L2-3, and this is the patient previous fusion, X-rays, and this is the MRI. The patient had clearly developed adjacent segment disease, both rostrally and caudally, and also there was significant amount of end plate modic changes. And when I see an end plate modic changes with significant amount of sclerosis here, that bone is very hard. So I tend to push it the maximum by trying to put about 14 or 16 kg on that level, because I know that bone is so hard, it's not going to collapse around it. And so we did in 2 stages. First, we did the lateral part where you can see that I have it very nicely corrected. And this is the AP and lateral X-rays. Now that we have corrected the rostral curve, we still have the fractional curve here, which we need to correct. And instead of doing an A-lift, we just proceeded to do a posterior approach and put in an interbody cage at that level, and we corrected it. And I try to, every case I approach, I try to find a reason why MIS cannot be done in this particular case. And I believe that every case should be MIS, and why it is not is, is what I'm trying to figure it out, so that I try to do most of my cases as MIS. So this is the final CT scan. So between the 2 steps, after the first step, I did a CT scan just to make sure, and also assess her symptoms if something changed, or if there is a new radiculopathy somewhere else because of me mobilizing the spine. And post-operatively, she was on PCA because she was on a lot of opioids in the past, and eventually was discharged. She did very well after the surgery. And this is the next case. Severe back pain, sleeps on a recliner, had a previous fusion, L3 to S1. You can see the adjacent segment disease both on the CT scan and on the MRI. And this particular patient really didn't have a lot of leg pain, mostly back pain. And we did a standalone lateral approach on this patient. And as you can see here, we corrected that particular deformity fairly well with a lateral approach. And that was a standalone cage, and the patient did phenomenally well. And at this point, the company I was using did not have a lateral plate. If I had to do it now, I would put a screw above and below using a lateral plate, trying to avoid the posterior. And especially if you're doing a standalone, make sure the patient is not osteopenic or osteoporotic, because they can collapse the vertebral body around it, whether it is rostral or caudal, and come back with a reduced foraminal height and significant radiculopathy. And next case, Patient had also a previous fusion, the level 2 levels above, you can see that has significant stenosis, especially as the adjacent segment. And then the patient had some retrolysis, but since the patient already had a fusion, I couldn't just do a decompression only. And after putting in the standalone cages, the patient did phenomenally well. And my combination for the standalone cages is always BMP and DBM. Whether it is standalone or it is because in the lateral you have to remember that there is no autograft that you can get when you do a laminectomy, and this is pretty much the same CT scan. The bone can grow through the cage, and this is very important. The bigger the cage, the wider the cage, the more surface area for the bone growth. And so this is one of the other timelines. You can see I have significantly changed. The difference between the first and this case is about 6 months. And over a period of 6 months, I reformed enough to get to the disc space much faster than the earlier cases. And this is one of the other cases, very large patient.
I'll interrupt you, Karthik.
Yes.
Dr. We'll have to kind of come to a conclusion here because we're at the hour and we have to run off and
Yes.
we have time slot. So great stuff. Can you come to a conclusion then?
Yes. So a couple of things. Cage selection, use the one that gives you the maximum amount of surface contact. I shy away from the expandable because the expandable cage have a solid titanium plate. Usually, as you can see, this is an expandable. It reduces if you are buying a new house and has 4 rooms, you can only use 2 rooms. And it's kind of like that. You have a lot less space. And the lateral A-lift is one of the ones that I rather not use because the size of the cage that I'm able to put in and the amount of correction I'm able to get in is significantly smaller with the lateral A-lift. Same thing with the prone lateral. I believe it's more of an industry-driven innovation and so forth. And so for me, one last, for the first case, make sure you, if you haven't done a lateral or a anterior to Psoas, have a cadaver lab arranged on a one-on-one basis, and then open the abdomen, check all the relations, anatomical relations, and at L3-4 is probably the most ideal level and okay to do a large incision in the beginning. And said that this is my LinkedIn profile QR code. If anybody would like to contact me, please, I encourage it if you need anything lateral. Thank you so much for the opportunity.
Dr. Madhavan, really nice job. Obviously, a lot of intricate detail knowledge. Congratulations on that. One quick question. So a lot of the cases in these textbooks are orthogonal degenerative conditions where there's a kind of a one-plane focus. What about patients where there's a rotatory deformity, where there's spinning of the spine in the axial or coronal or combination planes? So what to do with these very sophisticated approach technologies when we have a distorted, twisted anatomy?
Well, if the anatomy is significantly twisted, I would say if it is more than 20 degrees or so forth, it's very difficult to correct with MIS. I would just go do it open and take out the facets and things like that. Once you put in a large enough cage, the facets joints unlock. And then either you can use a pre-made rod or you can bend the rod accordingly and pass it down. On my last case, that's what we did. We passed the rod down across from all the way from P10 all the way down to pelvis. And once we passed it, we brought the spine to the rod. And a lot of times when you're doing MIS, it is much easier because the amount of the threads that each screw tabs have is about 25 millimeters or even 30 millimeters. That helps you reduce it significantly and brings the spine to the rod than rod to the spine.
Hey, Karthik,
yeah.
that was a great talk, and I enjoyed your some of the cases you showed. Standalones, in my experience, especially in the lumbar spine, they have a high failure rate. So just be cautious, especially above large forces. The lumbar spine has lots of flexion, extension, lateral rotation. And early on in my experience, we did a ton of standalones, and it's very high failure rate in terms of pseudoarthrosis. And that's just been our experience. I do think, the implants have gotten better. The cages are more sophisticated. And, obviously, you can get a lot of, I'm a huge fan of indirect decompression. But nowadays, I mean, I've basically quit doing standalone. I think a lot of the surgeons that do a lot of lateral don't do standalone anymore just because it's a high failure rate. I don't know if you brace them or not, but that's been my experience, doing a lot of lateral.
I totally agree with you. And if I see any signs of osteoporosis, one thing I avoid is standalone. And the second thing is whenever I'm looking into doing a standalone, I put in screws above and below with a lateral plate going all the way up to the contralateral end of the vertebral body. And I try to stabilize it as much as possible. Now, once you have the contralateral vertebral body also engaged, you almost like a bicortical screw on ACDF. So that is one way I have minimized it, but I am very cautious on the ones that I choose for the standalone lateral.
We must come to a close. Thank you so much for joining us from New Jersey. Really wonderful insights and great presentation. Enjoyed having you here, and hopefully you'll come back to Seattle sometime.
Thank you, sir. Thank you very much.
Is that the